and very commonly facing in the all ICUs. So he is going to highlight the latest guidelines how to approach a patient with fever in ICU. Thank you for choosing this nice topic, Naresh. And I request Srikanth to introduce Naresh.
So thank you, sir. Good morning, everyone. This is Dr. Naresh. Has been in Omni RK since long. Recently moved to our Andhra hospitals as a consultant critical care, and he's even associated with ABC Hospital since long. He's been doing occasionally day duties and regular night duties for us. So today, this topic we have chosen based on the 2008 American Society Infectious Disease Society guidelines. So since then also, as per my knowledge and my searching on web, only those guidelines were there since the past 15 years. Some updated articles are there, but essentially the guidelines are the same since 2008. So we have prepared the class based on those guidelines, and after the class which will be dealing directly the pointers from the guidelines, we will discuss what we are practicing in our respective ICUs and how far we are able to achieve success in evaluating the causes of new onset fever in adult ICUs. Thank you so much, and Naresh, you can start the class.
Thank you, Srikanth sir and David sir. Good morning, everyone. Today we are discussing mainly about the evaluation of new onset fever in adult ICU patient mainly. So in some ICUs, measurement of newly elevated temperature triggers an automatic order set that include many tests that are time consuming, costly, and disruptive to patient and staff. Moreover, the patient may experience discomfort, be exposed to unneeded radiation, unrequired transport outside the controlled environment of the ICU, or experiences considerable blood loss due to this testing, which is often repeated several times within 24 hours and daily thereafter. In an era when utilization of hospital and patient resources is under intense scrutiny, it is appropriate to assess how such favors should be evaluated in prudent and cost-effective manner. So actually, the definition of favor is arbitrary and depending upon the purpose for which it is defined. Some literatures define favor as a core temperature of 38 degrees centigrade or 100.4 degrees Fahrenheit, whereas other sources define favor as two consecutive elevations of 38.3, that is 101 degrees Fahrenheit. In patients who are neutropenic, fever has been defined as a single oral temperature of 38.3 degrees centigrade, that is 101 Fahrenheit, in the absence of an obvious environmental cause or a temperature elevation of 38 degrees per 1 hour. A variety of definitions of fever are acceptable, depending on how sensitivity and indicator of the thermal abnormality an ICU practitioner wants to utilize. So recommendations for measuring temperature wells. Choose the most accurate and reliable method to measure the temperature based on the clinical circumstances and the patients. Temperature is most accurately measured by the intravascular, esophageal, or bladder thermistors, followed by rectal, oral, tympanic membrane measurements in that order. Auxiliary measurements, temporal artery estimates, and chemical dot thermometers should not be used in the ICU. Rectal thermometers should be avoided in neutropenic patients. So any device used to measure temperature must be maintained and calibrated appropriately using the manufacturer's guidelines as a reference. Any device used to measure temperature must be used in a manner that does not facilitate spreading of pathogens by the instrument or the operator. The site of temperature measurement should be recorded with the temperature in the chart. The recommendations for obtaining blood. Initially, when we suspected fever, first of all, we are doing the blood cultures. So recommendations for obtaining blood cultures. Obtain 3 to 4 blood cultures within the first 24 hours onset of fever. Every effort must be made to draw the first culture before the initiation of antimicrobial therapy. They can be drawn consecutively or simultaneously unless there is a suspicion of an endovascular infection, in which case separate venipunctures by the timed intervals can be drawn to demonstrate continuous bacteremia. Additional blood culture should be drawn thereafter only when there is a clinical suspicion of continuing or recurrent bacteremia or fungeremia, or for the test of cure 48 to 96 hours after initiation of appropriate therapy for bacteremia or fungemia. Additional culture should not be drawn as a single specimen but should always be paired. For patient without an indwelling vascular catheters, obtain at least 2 blood cultures using strict aseptic technique from the peripheral side by separate venipunctures after appropriate disinfection of the skin. For cutaneous disinfection, 2% chlorhexidine gluconate in 70% isopropyl alcohol is the preferred skin antiseptic, but a tincture of iodine is equal to effective. Both require 30 seconds for drying time before proceeding with the culture procedures. Povidone iodine is an acceptable alternative, but this must be allowed to dry for 2 minutes. The injection port of the blood culture bottle should be wiped with 70 to 90% alcohol before injecting the blood sample into the bottle to reduce the risk of introducing contamination. Label the blood culture with the exact time, date, and anatomic site from which it was taken. Draw nearly 20 to 30 ml of blood per culture bottle. Paired blood culture provide more useful information than the single blood cultures. Single blood cultures are not recommended except in neonates. These are the commonly using methods and commonly obtained pathogens based. This is purely based on depending upon the ICU, the bioflora of the other surroundings, and the community acquired disease. This is the somewhat techniques and most common pathogens. The second common, if we suspected fever, first of all, we have to search for intravascular catheter infections. The relative risk of bloodstream infections caused by the various intravascular devices ranges widely depending upon the length of the device, the type of the device, the patient population, the technique used in the insertion, for frequency of manipulations, and the time they have been in place. Recommendation for management of intravascular catheters. Examine the patient at least daily for the inflammation or purulence at the exist site, or along the tunnel, and the assess of the patient for the signs for venous thrombosis or evidence of embolic phenomena. Any expressed puncture from the insertion site should be gram-stained and cultured. If there is evidence of tunnel infection, embolic phenomena, vascular compromise, or septic shock, the catheter should be removed and cultured, and a new catheter inserted at the different site. With short-term temporary catheter like peripheral vascular catheters, non-cuffed central venous catheter, or arterial catheter, the catheter-related sepsis is considered likely. Suspect the catheter or catheter should be removed and catheter segment cultured. Blood culture should be obtained as well. With all short-term catheters, a 5 to 7 centimeters intracutaneous segment should be cultured to document the source of the bacteremia. With short peripheral venous or arterial catheters, the tip should be cultured. With longer central venous catheter, the intracutaneous segment and tip should be cultured. With the pulmonary artery catheter, the introducer and the pulmonary artery catheter should be cultured. Do not routinely culture all catheter removed from the ICU patients. Culture only those catheters suspected of being the source of the infection. It is not necessary to routinely culture infused specimen or the part of the evolution of the catheter-related infection, unless there is a clinical suspicion for infected infusate or blood products. The second most common is pulmonary infection and ICU-acquired pneumonia. Pneumonia is the second most common cause of infection occurring in the ICU and is the ubiquitous cause of fever, with the majority of cases occurring immediately ventilated patients. Occurring in mechanically ventilated patients. In an ICU, it can be difficult to determine whether the fever is due to pneumonia when the patient commonly have other non-infectious process producing abnormal chest X-rays and the gas exudations. So the chest imaging should be obtained. In most cases, an upright portable anterior posterior chest X-ray is the most feasible study to obtain. Posterior anterior chest X-ray with lateral view or CT scan of more information and should be obtained when clinically indicated, especially to rule out opportunistic infections in immunocompromised patients. Obtain one sample of the lower respiratory tract secretions for direct examination and culture before initiation of changing of antibiotics. Expectorated sputum, induced sputum, tracheal secretions or bronchoscopic or non-bronchoscopic alveolar larvage material can be used effectively. In pneumonia is documented by physical examination. If pneumonia documented by the physical examination and radiological evaluation, a decision to employ bronchoscopy or other invasive diagnostic approach should be considered based on individual, based on the availability of the local expertise. Respiratory secretions obtained for microbial evaluation should be transported to the laboratory and proceeds within 2 hours. Respiratory secretions that are judged to be appropriate sample by the laboratory should be evaluated by gram-negative stains and cultured for routine aerobic and facultative bacteria. Additional stains, rapid test, cultures, and other tests should be performed as epidemiological appropriate. Quantitative cultures can provide useful information in certain patient populations when assessed in experienced laboratories. However, quantitative cultures have not yet been sufficiently standardized, nor they have been shown to alter outcome for this technique to be considered the part of routine evaluation. Pleural fluid should be obtained with ultrasound guided for gram-negative stains and routine cultures if there is an adjacent infiltration or another reason to suspect infection, and the fluid can be safely aspirated and sent for cultures and other tests. The most common third source of infection in ICU fevers are the gastrointestinal tract. So many patients in ICU have diarrhea, which is often caused by the enteral feeding or drugs. By far, the most common entry cause of fever in the ICU is the Clostridium difficile. It should be suspected any patient with fever or leukocytosis and diarrhea who received an antimicrobial agent or chemotherapy within 16 days before onset of the diarrhea. So for evaluation GI tract, send one stool sample for Clostridium difficile common antigen or endotoxin immunoassay A and B or tissue culture assay. If the first specimen for Clostridium difficile is negative and testing is performed by an EIA method, send additional sample for C. difficile EIA evaluation. A second specimen is not necessary if the common antigen test was negative. If the severe illness is present and rapid test for C. difficile are negative for unavailable, consider flexible sigmoidoscopy for pseudomembranous, the pseudomembranous for Clostridium difficile. If severe illness is present, consider empirical therapy with vancomycin while awaiting diagnostic studies. Empirical therapy is not generally recommended if 2 stool evaluations are negative using a reliable assay, although it may be more cost effective than making the diagnosis. The empirical use of antibiotic, especially vancomycin, is discouraged because of the risk of producing resistant pathogens. Stool culture for other enteric pathogens are rarely indicated in patients who did not present to the hospital with diarrhea or in the patients who are not HIV infected. Send stool culture for other enteric pathogens and examine for ova and parasite only if the epidemiologically appropriate or evaluating an immunocompromised host. So test stool for norovirus is the clinical and epidemiological settings is appropriate. Testing for norovirus is usually only available in state laboratories and is usually performed in outbreak settings. Obtain consultation with infection control and public health authorities. So, in the urinary tract infection, for patients at high risk for urinary tract infection, or mostly post-kidney transplant or granulocytopenic patient with recent urological surgeries or obstruction. This patient needs clinical evaluation suggest a patient may have symptomatic urinary tract infection. A laboratory evaluation is necessary. Obtain urine for microscopic examination, gram-negative stains and cultures. Urine should be transported to the laboratory and proceed with 1 hour to avoid bacterial multiplication. If transport to the laboratory will be delayed for 1 hour, the specimen should be refrigerated. Alternatively, a preservative could be used, but is less preferable to refrigerator. Culture from the catheter patients showing that the bacterial growth greater than 10 to the power of 3 CFU per ml suggestive of the bacteremia or candiduria, but neither higher counts nor the presence of polyuria alone are of much value in determining the catheter associated bacteria or candiduria is the cause for the patient's fever. Gram stains of centrifuged urine will reliably show the infecting organism and can aid in the selection of the anti-infective therapy if catheter-associated urosepsis is suspected. Rapid dig tests are not recommended for patients with urinary catheters in the analysis of possible catheter-associated infections. So later we have to look for the sinusitis. If clinical evaluation suggests that the sinusitis may be the cause of fever, a CT scan of the facial sinuses should be obtained. If the patient has not responded to empirical therapy, puncture and aspiration of the involved sinus under the antiseptic conditions should be performed. Aspiration fluid should be sent for gram-negative stain and culture for the aerobic and anaerobic bacteria and fungi to determine the causative pathogen and its antimicrobial susceptibility. So recommendation for evaluation of fever within 72 hours after surgery. A chest radiography is not recommended during the initial 72 hours of post-operatively if patient is the only indication. If the fever is the only indication, there is no need of chest radiography. A urinary analysis and cultures are not mandatory during the initial 72 hours post-operatively if the fever is the only indication. Urine analysis and culture should be performed for those febrile patients having indwelling bladder catheter greater than 72 hours because there is the chances of a microaspiration before perioperatively or post extubation. There is a minimal chance of minimal aspiration if the fever present after 72 hours of the surgery, then only we have to consider chest x-ray. Before 72 hours, if the patient has fever, there is no need of chest x-ray, and like that, if the patient fever is before less than 72 hours, there is the less chances of catheter-induced infections. So, if post-operative patient only consider if the fever continues after 72 hours of the surgery. Surgical wound should be examined daily for infection. They should not be cultured if there is no symptoms or signs suggestive of infection. A high level of suspicion should be maintained for deep venous thrombosis, superficial thrombophlebitis, and pulmonary embolism, especially in patients who are sedentary, have lower limb mobility, have a malignant neoplasm, or taking an oral contraceptive pills. So recommendations for evaluation of surgical site infection. Examine the surgical incision at least once daily for erythema, purulence, or tenderness as a part of the fever evaluation. If there is a suspicious of infection, the incision should be opened and cultured. Gram-negative stains and culture should be obtained from any expressed purulence obtained from level within the incision consisting with a deep incisional or organ or space surgical organ or space at surgical site infection. Tissue biopsies or aspirations are the preferable to swabs. Drainage from the superficial surgical site infection may not require gram-negative staining and culture because incision, drainage, and local care may be sufficient treatment and antibiotic therapy may not be required. Superficial swab cultures are likely to be contaminated with commensal skin flora and not recommended. Standard guidelines should be used to define burn wound infection. Recommendation for evaluation of central nervous system infection. If altered consciousness or focal neurological signs are unexplained, lumbar puncture should be considered in any patient with new fever unless there is a contraindicated to lumbar puncture. For a patient with a new fever and new focal neurological findings suggest a disease above the foramen magnum, an imaging study is usually required before lumbar puncture. If a mass is present, neurology or neurosurgery consultation be required to determine the optimal diagnostic approach. In febrile patient with an intracranial device, CSF should be obtained for analysis from the CSF reservoir. The CSF flow to the subarachnoid space is obstructed. It may be prudent to also obtain CSF from the lumbar space. In patient with ventriculostomies who developed stupor or signs of meningitis, the catheter should be removed and the tip should be cultured. CSF should be evaluated by gram-negative stain and culture, glucose, protein, cell count with differentials. Additional tests for tuberculosis, viral and fungal diseases, neoplasm, etc. should be performed as the indicated by the clinical situation. Other considerations. Mononucleosis syndrome after the blood transfusion has been broadly recognized as a cause of the heatic fever in post-surgical patients for more than 4 decades. Infections may be caused by the transmission of CMV, by the way, transfused blood cells in the blood products or from the reactivation of CMV by the transfusion-induced antigen stimulation. In symptomatic patient, symptoms usually being 1 month after transfusion. Silent source of infection including but not limited to otitis media, decubitus ulcers at the sacrum or the back of the head, perineal or perianal abscesses, and undetected retained Tamsons need to be carefully ruled out. The recognition and identification of these other less common infectious causes of fever require a careful history and physical examination, including the examination of all devices, drains, and hardware on the daily basis. Use of adjuvant markers for the evaluation of fever. Procalcitonin level elevations of greater than 0.5 mg per ml occur within 2 to 3 hours onset with higher levels observing along the continuum from the systemic inflammatory response syndrome. If we suspect if procalcitonin is 0.6 to 2, severe sepsis 2 to 10, and septic shock greater than 10. The most importantly, viral infections, recent surgeries, and chronic inflammatory states are not associated with an increment to procalcitonin level. Traditional endotoxin detection systems such as the chromogenic luminous lysate assay have been hampered by contamination concerns, cumbersome techniques, and variable sensitivity and inconsistent correlation to the presence of true gram-negative infection. However, kinetic luminometric anti-assay, that is endotoxin activity assay, uses an antibody to the considered lipid A component of endotoxin to form an antibody-antigen complexes capable of stimulating a detection host neutrophilic respiratory burst in an ex vivo assay. In multicentric ICU study, the endotoxin activity assay demonstrates the high negative predictive value for gram-negative infections. Tumor necrosis factor alpha, interleukin 6 C-reactive protein, and a triggering receptor expressed on myeloid cells have been tested as a method of discriminate true infection from the other inflammatory states but have not yet been validated. Serum procalcitonin levels and endotoxin activity assay can be employed as an adjuvant diagnostic tool for discriminating infection as the cause of the fever or sepsis presentation. So recommendation for recognizing non-infectious cause of fever. Consider all new medications and blood products in the patient has received. Ideally, if the suspected drug can be stopped, do so. So if the drug cannot be stopped, consider a comparable substitute. Fever induced by the drug may take several days to resolve. Establish a temporal relationship between fever and the offending agent may be helpful in the establishing the diagnosis. These are some examples of non-infectious fever. Example: acute cholecystitis, acute myocardial infections, adrenal insufficiency, blood product transfusion, cytokine-related fevers, drug fevers, fat embolism, fibrillatory phase of acute respiratory distress syndrome, gout, heterotropic ossifications, intracranial bleed, pancreatitis, pulmonary infections, pneumonitis without infections, stroke, thyroid storm, transplant rejections, tumor lysis syndrome, and venous embolisms are the most commonly non-infectious cause of fevers. So recommendations of empirical therapy of fever. When clinically evaluation suggests that the infection is the cause of fever, consideration should be given to administering empirical antimicrobial therapy as soon as possible after cultures are obtained, especially if the patient is seriously ill or deteriorating. Initial empirical antibiotic therapy should be directed against likely pathogens as suggested by the suspected source of the infection, the patient risk for infection by the multi-drug resistant pathogen, and local knowledge of antimicrobial susceptibility pattern. Thank you, sir.
అయిపోయిందా?
Sir, actually topic more over other ICs లో ఎలా evaluate చేస్తున్నాం అనే దాన్ని. ఇవి కొన్ని మనకి రెగ్యులర్ గా చేసేవి ఎన్కౌంటర్ చేయడానికి మనం రెగ్యులర్ గా ఏమైతే చూడాలి అదర్ ఐసీ ఆస్పెక్ట్ వ్యూ లా అని చెప్పేసి గైడ్ లైన్స్.
Okay, Naresh, good presentation. My advice is once you prepare the presentation, instead of reading all the sentences on the slides, better you prepare, take the articles and prepare and explain of each thing.
అవును సార్.
అలాగా ప్రిపేర్ చేయండి సార్.
అలాగే సార్.
శ్రీకాంత్ బచ్చు గైడెన్స్ కి. శ్రీకాంత్ బచ్చు అక్కడ గైడెన్స్ కి.
శ్రీకాంత్, you take care of that.
Sir.
Hello, any questions? Hello, Anna Satish.
Hello.
అడగండి.
Reliability of surface cultures means like sputum culture or pus from the bed sore and chronic non-healing ulcer in the foot. If you send the culture, it shows some bug, and consultants are constantly on that, and they ask us to go for as per the culture report. But patient is otherwise stable hemodynamically, or when the patient admitted with a bed sore and immediately send the culture, it is showing a Acinetobacter baumannii, immediately jump onto colistin. So how far it is? Like, is there any specific way to identify whether it is a true bug or something like commensal there?
So usually patient was symptomatic, we will consider this as the pathogenic bacteria. If patient was asymptomatic, there is no elevation of total counts. We will mostly not do anything for that. If the symptoms are aggravated, it will take as the positive culture.
Is there any other way to something like, because symptoms will be there, otherwise why should he be in ICU? He's having fever, but thing is whatever you are looking may be not right. You must have to dig further and find out what is really happening. Either the new infection happened in the lung, or new infection happened in the bladder or something, we don't know. But simply looking at this, whatever that is visible to us, how far we can reliable on that?
At the same time, we can send the blood cultures also, sir. So
Sir,
that-
basically with infections, as you are mentioning, better to send the tissue cultures. So just
Exactly.
wipe off all the surface, these things, and send
Yeah.
the tissue for culture. So we here in the hospital, we send in the theater, they send clean nicely with saline and then send for a tissue culture. So that will give a clue whether the patient is having infection or not. Anyway, as you mentioned, we have to check for the other causes of infection. And if nothing is there, then we can treat here. But tissue culture is definitely a treatment. We have to treat. Surface we cannot treat. But one clue will give, sir. It will give a clue. Suppose this, if we are not able to identify the other cause, and
Yeah.
this what you have sent for a pus or surface, this one culture, that will give that whatever if that is the antibiotic doesn't suit the organism, the multi-drug resistant organism, patient is not responding clinically, I think you can start it.
Okay, sir.
So
Thank you.
ultimately,
Sir,
you see that clinically and then reports.
sir, actually guidelines లో కూడా అదే ఇచ్చారు సార్, అంటే లైక్ పస్ కల్చర్స్ అవి తీసినప్పుడు ఈ సేయింగ్ దట్ స్వాబ్ స్టిక్ కల్చర్స్ పంపిస్తాం కదా సార్, యాజ్ పర్ ద గైడ్లైన్స్ దే ఆర్ అన్రిలయబుల్ సార్. As Srinivas sir was mentioning, tissue culture is better suited than swab stick cultures as per the guidelines. That point is mentioned. Sir, I
What
have
about the
one more.
sputum culture? Yeah, okay.
Sir,
Sputum culture.
స్పోటమ్ కల్చర్ anyhow పంపిస్తాం, అంటే వాల్యూమ్ అది పంపిస్తాం సార్. ఇది ఎస్పెషల్లీ ఆ పస్ కల్చర్ వూండ్, ఇన్ఫెక్టెడ్ వూండ్స్ ది గైడ్ లైన్స్ ఉంది సార్. అంటే స్వాబ్ స్టిక్ కల్చర్స్ రెగ్యులర్ గా మనం డిప్ చేసి అలా పంపిస్తాం కదా. సో యాజ్ పర్ దెమ్ ఇట్స్ నాట్ రిలయబుల్. అంటే సిగ్నిఫికెంట్ అమౌంట్ ఆఫ్ దట్ పస్ ఆర్ టిష్యూ కల్చర్ షుడ్ బి డన్, ఇన్ఫెక్టెడ్ టిష్యూ కల్చర్. సార్ బ్లడ్ కల్చర్ ఒకసారి డౌట్ సార్, అంటే హౌ పీపుల్ ఆర్ సెండింగ్ బ్లడ్ కల్చర్, అంటే గైడ్లైన్స్ లో బాగా స్ట్రాంగ్ గా అప్ టు 3 సెపరేట్ ఏరియాస్ 20 to 30 ml ఆఫ్ బ్లడ్ అలా ఇచ్చాడు అమెరికన్ గైడ్లైన్స్ లోని. హౌ వీఆర్ సెండింగ్ అని?
Definitely 2 different sites are important. Minimum 2
Yes,
is
sir.
good, 3 is excellent. 2 is good, 3 is excellent, 4 is luxury.
Okay.
That is one side. Second thing is 2 different sites. If there is an indwelling site, that has to be also included as a third site.
Okay, sir.
Yeah, what we are doing, actually we have to send one anaerobic set and one aerobic set. But anaerobic set may not be required routinely in our ICUs unless it is strongly indicated. We are sending aerobic set to 10 ml of each. Actually, they advised 30 ml, as Satish said, 30 ml is 99.9% of trying to get the, and 20 ml is around 98%, and 10 ml is 95% to get the yield of the bacteria. 10 ml in each bottle of 2 bottles. That equals to 1 aerobic set. That is mandatory of 2 different sites. For endocarditis, suspecting endocarditis, the 3 sets of duration of 30 minutes gap. Ante kadana? 30 minutes gap for 3 sets should be sent.
And also he's
Indwelling
asking us to label, no, sir, from the site it's drawn
Yes.
and all.
Yes, definitely. It should be labeled. Where your catheter, we have to label from the catheter. Femoral, we have to. Majority times we get the femoral. Femoral is going hemolytic streptococci, and this brachial is no growth is obtained. So then we cannot treat the patient. It may be a contamination. So whenever you get both sides, the patient is symptomatic, then only.
సార్ ఒకసారి కల్చర్స్ పంపించిన తర్వాత మళ్ళీ 48 to 78 అవర్స్ సెకండ్ సెట్ ఆఫ్ కల్చర్స్ పంపించమని చెప్తున్నారు నార్మల్ గైడ్ లైన్స్ లో అలా ఉంది. మరి మేబీ పంపించుకోవచ్చు అని చెప్పేసి సార్, అది ఎవరైనా చేస్తున్నామా సార్?
For all blood cultures?
లేదు సార్, అంటే ఆఫ్టర్ 72 అవర్స్ తర్వాత మన యాంటీబయాటిక్ పెట్టిన తర్వాత 72 to 48 అవర్స్ తర్వాత సెకండ్ కల్చర్స్ కొన్ని ఆర్టికల్స్ లో పంపించమని చెప్తున్నారు సార్. అంటే ఇన్ఫెక్టివిటీ లెవెల్స్ కంపేర్ టు ఫస్ట్ కల్చర్ సెకండ్ కల్చర్ ఎలా ఉంది అంటే
Maybe it depends on not mandatory. Once patient is not responding, then after 48 or 72 hours, if patient is responding, okay, then we need not send, I think.
అంటే ఇది 48 యాంటీబయాటిక్ స్టార్ట్ చేసినాక 48 to 72 అవర్స్ తర్వాత why they may be recommending is because there might be a new infection happen within this 48 hours or 72 hours. Incubation period 48 hours తర్వాత హాస్పిటల్లో ఉంటే the patient is not responding, not for to look into the whether the patient is responding to existing antibiotic or not, whether the patient has a new infection, they might be recommending, but otherwise to see the intensity of disease decrease or anything, not required. This is only in case, as David mentioned, the patient is not responding.
Okay sir.
And there are a lot of other factors why the patient will not respond. It is not only an infectious thing, like it can be a vasculitis, it can be a connective tissue disorder, it can be a malignancy. So that all things also has to be ruled out.
Okay.
సార్ ఇంకొక 1 or 2 పాయింట్స్ క్లారిఫికేషన్ కనుక్కున్నాను సార్. ఇంకోటి హౌ అంటే యాజ్ పర్ ద గైడ్ లైన్స్ యాక్చువల్లీ దే ఆర్ నాట్ రికమెండింగ్ ఈవెన్ auxiliary temperature measurement in ICUs. And 15 years back, when still we are following, or any other places you are using regularly other forms of measuring core temperature on regular basis? What are the options we have apart from measuring auxiliary?
Nasopharyngeal temperature probe in all ventilated patients.
Okay, sir. Conscious, I mean, like, not non-ventilated cases, how comfortably we can measure? Auxiliary is far more
difficult to measure.
Actually, what you are doing in ICU, as you said, all ventilated patient nasopharyngeal probe we are connecting, and all conscious patients are stable patient. We are using separate thermometers, so we can use the oral, and patient is not on ventilator or NIV or anything, auxiliary. Majority we are using auxiliary only. We are adding +1 for the auxiliary. So majority the times sister will not put the probe properly exactly in the axilla. They put somewhere around the axilla, and we are getting normal temperature 99. Always whenever you ask, they will say 99 temperature. And the skin is so hot, and once you properly ask them to put, or you put yourself properly in the axilla and check it, then you will get 1 or 2 temperature. These things are so many times happening in the ICU. So because every time I am trying to do echo, my hand is touching the chest, patient is so hot. Then I ask, what is the temperature? Sister said normal. Majority times it happened. Then I asked them to check the temperature. They said just now only checked, sir. Then I told again, you repeat it immediately. Then you will get 1 or 2 temperature. So I don't know how to solve this problem. We cannot put the rectal temperature. It is difficult, and it is practically it is not very easy. And orally, the patient is not able to put orally because patient may be semi-conscious or on NIV. And you cannot put nasopharyngeal probe for every patient in the ICU. What is the solution for that?
Actually, మనం చూసి axillary least
But most practically doing, no?
Sir, అదే నా డౌట్. మోస్ట్
Ah,
ప్రాక్టికల్లీ
most
కన్వీనియంట్
practically doing 99%. How many people are doing
99%.
nasopharyngeal and rectal?
నాసోఫారింజియల్ వెంటిలేటెడ్ పేషెంట్ లో నాసోఫారింజియల్ వాడుతాం సార్, ఎందుకంటే సడేషన్ అంటే దాని
That is correct. What about other patients?
అదర్
How many
పేషెంట్స్
patients on ventilator in ICU? Maybe 2-3 patients out of 10. What about the other 70 to 80% of the patient? Practically, you are using only axilla.
యాక్సిలరీస్.
అంతే. దాన్నే కొంచెం కేర్ఫుల్ గా జాగ్రత్తగా వాళ్ళ ట్రైనింగ్ ఇవ్వాలి. ఎక్కడ పెట్టాలి యాక్సిల్లాలో? వాడు యాక్సిల్లాలో పెట్టమంటే ఎక్కడో తీసుకెళ్లి పైన ఎక్కడో టిప్ కొంచెం టచ్ ఎలా పెడతారు.
ఇంకే సపరేట్ థర్మోమీటర్స్ వాడుతున్నప్పుడు ఓవరాల్ తీసుకొచ్చాము సార్. యాక్సిలరీ మీద కొంచెం పై లైన్ లో ఉంది ఓవరాల్ థర్మోమీటర్స్.
ఉంది కానీ ఓవరాల్ గా ఇప్పుడు ఎన్ఐవి ఉంది. ఓవరాల్ ఎక్కడ పెడతాం? ఆ పేషెంట్ డ్రౌజీగా ఉంటాడు. ఓవరాల్ గా పెడితే కొంచెం సేపటికి అది లోపలికి వెళ్ళిపోయి ఉంటుంది. నోట్లో పెట్టి అటు ఇటు చూసుకుని వస్తారు. ఏదమ్మా థర్మోమీటర్ అంటే కనబట్టలేదు అంటారు. అలా ఉంటది. లేదా ఆడు కొరికేసాడు అనుకో గట్టిగా, ఇరిటేబుల్ పేషెంట్ పుట్టిన ఓరల్లీ నవ్వులే కొరికేస్తాడు. అది వెళ్ళిపోతే మెర్క్యూరీ. ఇట్ ఈస్ వెరీ డేంజర్ టు పుట్ ఆల్ పేషెంట్స్ ఇన్ ఓరల్. సేఫ్ ఈజ్ axilla. Practically, at least axilla you have to put it properly. Nurses should be trained properly. Otherwise, they will give a wrong information, wrong temperature.
Sir, two more areas of concern, sir, I wanted to discuss. One is like post-surgical cases, sir, and especially after major surgery and all. So we can practically get due to either infection, either pre-existing to surgery or some infection caused due to surgery and all. And inflammation will be there, no, sir. Especially with major surgery, this inflammation will be high. How we are going to approach these kind of cases, and how exactly like what we are going to treat an inflammation or infection?
No, you mentioned already up to 72 hours. Chances of infection post surgery is less. Once the patient is after 72 hours, patient is still having the fever, then we have to search for that new onset of fever in the ICU, like pneumonia or SSI, surgical site infection.
Site infection.
That is most common, surgical site infection and intraoperative contamination of and pneumonia and urinary tract infection,
urinary tract infection.
RBSI. All these things should be ruled out. He mentioned slides one by one. So hospital acquired infection should be ruled out after 48 to 72 hours.
Okay.
Or a patient is already taken for surgery,
Some
or
infective focus.
infective focus perforation or something else to treat the cause of infection. That should be focused. Again, we have to look for any collection in the abdomen of anything. So take the cultures. That protocol is there already.
And regarding this, especially in traumatic brain injuries and post craniotomy, those sort of central fever, how managing, sir? There is no infection practically.
Correct, but you send the cultures and the procalcitonin, the CBC and peripheral smear, rule out all possibility of infection first, because if the infection is the source, if you think that it is a central cause, and it may be going to be a big mistake. But after ruling out everything, then still patient is discuss with neurosurgeon. What practically we are doing. Neurosurgeon and what is the chances of central like brainstem bleed, all these things. Most commonly, patient is hemodynamically stable and all sources are ruled out, then okay, we can think of this thing.
బ్రోమోక్రిప్టిన్ సెంట్రల్ ఫీవర్ లో చేస్తుందని కొన్ని ఎక్కడో 1 or 2 గైడ్ లైన్స్ లో చదివాను సార్. ఎవరైనా యూజ్ చేస్తున్నారు బ్రోమోక్రిప్టిన్ అంటే యూజువల్ గా దాని కాంప్లికేషన్స్ లో హైపోథెర్మియా ఉంది. సో దానికి ఏమైనా వాడుతున్నారేమో.
మేమేం చేస్తున్నాం అంటే ఇండోమిథాసిన్ వాడుతున్నాం ఆల్ ట్రామాటిక్ బ్రెయిన్ ఇంజరీ పేషెంట్స్.
ఓకే.
దేర్ ఇస్ ఏ కాంబినేషన్ ఇండోమిథాసిన్ విత్ ఏదో డ్రగ్ ఉంది, బ్రోమోక్రిప్టిన్ కాదనుకుంటా. We are using routinely. then patient that the temperature is coming down.
మేము ఒక 4-5
That should be
పేషెంట్స్ కి
negative.
బ్రోమోక్రిప్టిన్ ట్రై చేసాం సార్. మరి ఎలా తగ్గింది కానీ కొంచెం హెల్ప్ అయినట్టు అనిపించింది.
అదే after rule out everything. If you temperature if infection is there, then it may mislead కదా.
అవును సార్. ఆఫ్టర్ అంటే రూల్ అవుట్ చేసుకున్న తర్వాత
అదే
సిఆర్టీలు ప్రోకాల్స్టన్స్ కౌంట్స్ ఇవన్నీ మనం క్లినికల్ గా ఏదో రీజన్స్ ఏమీ లేనప్పుడు దాన్ని సెంట్రల్ ఫీవర్ కింద తీసుకున్నాం. సెంట్రల్ ఫీవర్స్ కూడా వెరీ హై గ్రేడ్ లో వస్తాయి విత్ కౌంట్స్ అవన్నీ నార్మల్ గానే ఉన్నప్పుడు ఒక్కసారి 2 or 3 times బ్రోమోక్రిప్టిన్ ట్రై చేసాం సార్. బట్ మరి వాడికి ఏమైనా ప్రైమరీ కాజ్ తగ్గిందో తెలియదు కానీ తగ్గినాయి ఫీవర్స్.
ఇంకా another doubt from my side, majority times there is a clash between the primary and ICU intensivist or ID specialist. One person will tell stop all these antibiotics. It is a drug fever. Another primary consultant may tell no, we have to continue antibiotics. How can you stop antibiotics? Patient may deteriorate. So how to deal with this problem?
ఇది డిఫికల్ట్ సార్, చాలా అందరికీ డిఫికల్ట్. మేము యాంటీబయాటిక్స్ ఆపాలంటే ఫస్ట్ మనకి ఏమైనా ఇన్ఫెక్షన్ సోర్స్ ఏమైనా యాంటీబయాటిక్ ఆపాలంటే మనకే కొంచెం టెన్షన్ వస్తుంది సార్. డ్రగ్ ఫీవర్ అని చెప్తారు.
Mentioned in your slide, you select for alternate antibiotic or alternate thing.
అవును సార్, అవును.
But Satish and Jekina and other seniors can enlighten on this.
Satish sir may be better judge.
Sir,
What you
Sir,
are
in
doing? Patient is primary concern or the ID specialist come to hospital and he said stop all antibiotics. It is drug fever. How do you evaluate and how do you solve this problem? You don't want to stop. Primary consultant don't want to stop.
so practically I have 2 patients right now, neuro patients, craniotomy, drain is there, developed fever, and probably it is like respiratory infection or neuro infection, post-operative infection. So escalate the antibiotic first, send a procalcitonin and evaluate for all other possibilities of fever, like send urine culture, blood culture, sputum culture or ET culture. So at that point of time, like patient is getting better. So credit goes to the surgeon because he said he want to escalate the antibiotic because you don't want to take risk, but I did not get any culture positive. So now the point is day 5, we have to de-escalate the antibiotic, that is meropenem and vancomycin. So at that point of time, I would go with the procalcitonin, and the procalcitonin is less. I'll stop the antibiotic. That's all.
Mohan Rao, what is your opinion to stop all antibiotics? Drug fever.
Sir, actually, drug fever we can't diagnose. As Satish sir mentioned, if we rule out all other infections and procalcitonin is negative, we can think it's of a drug fever. But really in these circumstances, the patient is having a fever, procalcitonin negative, even without infection is a challenge. One. So definitely if a procalcitonin is negative and fever is there, then I would stop. But as soon as you stop the drugs, drug fever will not come down. It will take 6 weeks sometimes to come down. So this is a challenge. So we need to look into the clinically patient will have fever, but if the patient is having breathless or other than fever, the patient is breathless or shock or some other tachycardia, clinically something going wrong, then I would not stop antibiotics. Only a fever I would like to try, as Satish sir mentioned.
Oh, when fever is continuing in spite of antibiotics, the trend is to escalate the antibiotic కదా. దీనికి తగ్గట్లేదు, ఇంకోటి చూద్దాం, ఇంకోటి యాడ్ చేద్దాం అని.
అట్లా కాదన్నా, ఇప్పుడు పేషెంట్ కి ఓన్లీ ఫీవర్ ఈజ్ నో అదర్ క్లినికల్ సింప్టమ్స్, బికాస్ న్యూరలాజికల్ ఫీవర్, సెంట్రల్ ఫీవర్ ఉండొచ్చు, డ్రగ్ ఫీవర్ ఉండొచ్చు, దో అదర్ కాజెస్ ఆర్ ఆల్సో దేర్ ఫర్ ఫీవర్, సో అదర్ దాన్ ఇన్ఫెక్షన్. సో వీ నీడ్ టు లుక్ ఇన్ టు దట్ థింగ్స్. And once we rule out the fever, then we can, infection, then we can stop the things.
Okay, you can try stopping antibiotics.
Yes,
All
yes, sir.
All
And some of
antibiotics
the
are
some of the, yeah, all antibiotics means all. And some of them, what they do is, practice is, they stop antibiotics. If they not suspecting any infection, they wait for 48 hours to 72 hours, and they send for a cultures again. All cultures they send. So if any growth is there, then they'll restart. Sir, Satish sir, do you agree?
Sir,
Mohan sir, Mohan Rao, what is your opinion?
sir, the same thing happens, sir. Even the patient is on meropenem and vancomycin. 5 days after patient again developed fever, 102. Persistently, it was 102, recultured the patient. And we don't have any option. We have to go with colistin because the more than 10 days in ICU, intubated, ventilated, post CNS surgery. Patient is on meropenem and vancomycin, previously suspected meningitis. 4 days or 5 days, he was okay with meropenem vancomycin. Now again, there is another fever bout, and we are looked into urine culture, blood culture, ET culture, everything sent. We don't have an option. We have escalated to some colistin-based medicine with another BL-BLA combination. We continued, and we are looking into vancomycin trough levels, and we are continuing vancomycin also. Hello?
Yeah.
So I don't have an option right now.
Okay. Your blood culture is not growing anything. Still, patient is running with fever, and your counts are high.
Yes.
But we are not get any source.
No.
Will you
we did not.
continue? Huh? Yeah.
I have escalated that.
Usually these things will happen. You don't get any source. Cultures are negative, but still patient counts are high. Temperature is high. Tachycardia.
Hypotension.
No hypertension. Mostly.
Yeah, it is. He has hypotension. He is in sepsis.
Hypertension, definitely. We have to keep MDR infections like carbapenemase. Even NDM is more common in India. 80% of the carbapenemase are NDM only. So what we are doing nowadays, Javishepta we are starting, and in between, suspecting carbapenemase. But in India, 80% are NDM. I don't think only Javishepta is sufficient. We have to start NDM bugs also, like colistin or tigecycline and polymyxin B, including Javishepta.
Yeah, I gave the same thing. Now I continue. I given polymyxin B. I given cefepime 2 grams, sulbactam 2 grams TID, because that is one regimen which can take care of Acinetobacter and.
Yeah. Now presently sulbapime is there. Sulbapime means cefepime plus sulbactam 2 plus 2 grams. Are you using that?
Yeah, I have used it. This patient.
For only Acinetobacter?
Suspected Acinetobacter, because I don't have anything. Either it can be NDM or Acinetobacter. That's all. My hospital antibiogram shows the same thing. So I discussed with Balaji of CMC Vellore. He is very fond of cefepime and sulbactam. I discussed with him. So with his guidance, I started him on cefepime 2 grams TID, sulbactam 2 grams TID. Then
phase on sulbapime. Drug is coming 2 plus 2 grams, 4 grams TID adi.
2 grams TID of cefepime, 2 grams TID of sulbactam.
Okay.
And he said to continue add polymyxin over that.
So sulbapime plus polymyxin.
And gram-positive MRSA coverage, either vanc or linezolid.
You are in touch with Balaji?
Yeah, regularly.
We will respond.
He is a perfect guy, no? Whenever you call, he will respond. Better than our Apollo Chennai people.
All cutting it. Any questions, Anna? Any doubts, suggestions? Mohan Rao Mohan sir respond avaledu. Left.
Mohan Rao sir left side. Mohan sir.
Might be busy. There are no doubts. My suggestion is, if any doubt or any problem of infection or non-infection or patient is having MDR infections or any issue is there, better to take the help of ID specialist legally and even for
Illegal.
illegally. But our once ID is costly, so because they will have regular visits and their bill will rise so much that is also important for financial aspect. So any suggestions? There is no doubts. We will close the session. Thank you, Naresh and Srikanth,
Yeah, thank you.
for a nice topic discussed. Thank you all the audience for
Thank you, sir.
active
Thank you.
participation. Thank you.
Thank you, sir.